Hello, awesome staff at the Northwest Kidney Center, particularly at, of course, the flagship unit in Kent, but a shout out to our sister unit in Panther Lake. Today, we're going to talk about the epidemiology of chronic kidney disease. So rather than focus on a particular aspect of dialysis care this month, I thought I would give a sort of a big picture talk on the growing problem and the economic burden of kidney disease around the world. If anything, you will realize from this talk that you have job security in working with people who have kidney failure. There are three objectives to today's talk. I want you to understand the incidence of chronic kidney disease around the world, recognize the impact of chronic kidney disease on mortality and disability, and finally, recognize trends in chronic kidney disease and dialysis over the past 30 years. Chronic kidney disease is defined as an abnormality of structure or function that lasts for more than 3 months. The global burden of kidney disease is growing. In 2017, there were 700 million cases of all-stage chronic kidney disease recorded, representing 9.1% of the world's population. And in 2023, there were 850 million people recorded as having chronic kidney disease, or 10% global prevalence. Since 1990, the global all-age prevalence of chronic kidney disease has increased by 29.3%. And around the world, 1.2 million people died from chronic kidney disease in 2017. And between 1990 and 2017, the global all-age mortality for chronic kidney disease increased by almost 42%. Chronic kidney disease imposes a substantial financial burden on global healthcare systems. In 2021, the prevalence of CKD among American Medicare beneficiaries over the age of 65 was 13.5%. But this group accounted for a quarter, so $77 billion, of total Medicare spending. The costs associated with chronic kidney disease have increased in America by 40% between 2011 and 2021. And globally, similar cost increases are expected and have occurred. So for example, in China, they spent $179 billion in 2019, and they're projected to spend $200 billion this year. Furthermore, chronic kidney disease leads to premature death, disability, lower quality of life, psychosocial harms, and in general imposes high costs on governments, patients, and their families. So the World Health Organization has classified chronic kidney disease as a major global health concern and included in the assessment of the global burden of disease. So let's talk more about the global burden of chronic kidney disease. According to the International Society of Nephrology Global Kidney Health Atlas, in 2023 there are about 850 million people, or approximately 10% of the world's population, who are living with chronic kidney disease. The aged standardized prevalence of CKD was about 1.3 times higher in women than men. That said, men are about 1.5 times more likely to receive dialysis or transplantation than women, and in part this is thought to be due to the fact that CKD tends to progress more rapidly in men than in women. The CKD prevalence has increased by 29% from 1990 to 2017. Mortality globally has increased by 42% during this period. So CKD was the 17th leading cause of death in 1990 and has now increased to the 12th leading cause of death as of 2017. And of course, chronic kidney disease leads a lot of people to be disabled. In 2017, CKD accounted for 7.3 million years lived with disabilities, 28.5 million years of life lost, and 35.8 million disability-adjusted life years. Not surprisingly, there are regional disparities in CKD burden around the world. In 2017, China and India accounted for 1/3 of the global CKD burden. China had 132 million cases, and India had 115 million cases, owing to, of course, their very large populations. But a lot of smaller countries also had very high CKD burdens, including Bangladesh, Brazil, Indonesia, Japan, Mexico, Nigeria, Pakistan, Russia, United States, and Vietnam, all of which had more than 10 million CKD cases. Some countries have had disproportionately high increases in CKD mortality. For example, in Central America, there's been a 61% increase in mortality between 1990 and 2017, where it is now the second leading cause of death. And in Asia, there's been a 61% increase in mortality during the same period, and it's now the fifth leading cause of death. Disability is also varied. The age standardized disability adjusted life year rates varied more than 15-fold among different countries. In 2017, the highest rates of disability from chronic kidney disease were in American Samoa, El Salvador, Micronesia, Marshall Islands, and Mauritius. And the lowest rates of disability from CKD were in Andorra, Finland, Iceland, and Slovenia. In a recent report from 2017 to 2020, chronic kidney disease prevalence in the United States was 13.9%, representing 35.5 million non-institutionalized U.S. citizens ages 18 years and older. Most of these were low risk, but about 11% were moderate risk, 2.7% were high risk, and 1.4% were very high risk for progression to end-stage renal disease. In Canada, based on a large cross-sectional study of 559,000 participants between 2010 and 2015, the CKD prevalence was 71.9 per 1,000 individuals, but there was significant geographic variation, particularly among the indigenous populations who had a twofold higher rate of CKD prevalence compared to the general population. So the prevalence of CKD among the indigenous population in Canada is 25%. In Latin America, in 2023, the median prevalence of CKD was a little bit higher than the global prevalence and ranged from 16.8% in Puerto Rico to 6.2% in Bolivia, with the highest, or with diabetes as being the major cause of kidney failure. In Europe, the CKD prevalence ranges from 3.3% in Norway to 17% in Germany, but among patients with diabetes, the CKD prevalence is up to 45% in Germany. In Asia, the CKD prevalence among the adult population is lowest in mainland China at 10.8% and highest in Mongolia, 13.9%, with Taiwan, Japan, and South Korea somewhere in between. And finally, in Africa, based on a meta-analysis of 98 studies, the overall CKD prevalence is 15.8%. Approximately 0.1% of the world's population has end-stage renal disease. The prevalence is reportedly higher among the affluent and lower among those who live in low or less affluent societies, just because the affluent countries can afford dialysis, and those people continue to live while those people who cannot afford it die of their kidney failure. In 2010, 2.6 million people received some form of kidney replacement therapy, whether it was dialysis at 78% or transplantation at 22%. This is projected to increase to 5.4 million by 2030, but is likely an underestimate of the actual burden of CKD, or the numbers of people who have CKD, because it's suggested that 2.3 million people will die prematurely, not without access to kidney replacement therapy. Approximately 80% of people receiving kidney replacement therapy reside in affluent countries, predominantly in parts of Asia and in North America. On average, around the world, treatment of kidney failure constitutes 2.2 to 3% of the total healthcare budget. It's up to 25% of Medicare's budget, but kidney failure patients represent only 0.1 to 0.2% of the total population. Of course, the corollary to what I said as above is that the proportion of people with kidney failure who do not receive kidney replacement therapy tend to live in poor countries, particularly other parts of Asia as well as Africa. The incidence and prevalence of kidney disease is expected to increase over time. In the United States, the incidence of ESRD is projected to increase by 11 to 18% by 2030, owing in large part to changes in age, race distribution, obesity, and the prevalence of diabetes. The ESRD prevalence is similarly expected to increase by 29 to 68% by 2030. The greatest increases in treated kidney failure incidence between 2011 and 2021 were in Jalisco, Mexico, Taiwan, the United States, Singapore, Indonesia, Malaysia, Greece, Brazil, and Bangladesh. In 2021, more than 50% of incident cases of kidney failure were due to diabetes. In Brunei, Jerusalem, Singapore, Malaysia, and Hong Kong. There are some European countries where diabetes is still a minority of causes, but around the world, diabetes remains the #1 cause of kidney failure. The largest yearly increases in incident-treated kidney failure due to diabetes between 2011 and 2021 occurred in Korea, Singapore, Taiwan, Uruguay, United States, Hong Kong, and Malaysia. Fortunately, the availability of kidney replacement therapies has grown worldwide. Between 1990 and 2017, the global incidence of dialysis has increased by 43%, and kidney transplantation has increased by 34%. Access to kidney replacement therapy is higher in affluent countries than resource-limited countries. So the global median prevalence of kidney replacement therapy is 823 per million population, but that varies a lot by region. It's highest in Taiwan at 3,679 per million population, followed by Japan at 2,696, followed by the United States at 2,465, compared to Western Europe, a little over 1,000, and it's lowest in African countries where dialysis is very scarce. According to an observational study from 122 countries published in 2008, there were 196,000 peritoneal dialysis patients worldwide, constituting 11% of the total dialysis population. Approximately 59% of these were in resource-limited countries, and 41% were in resource-abundant countries. In 2021, the countries with the highest utilization of peritoneal dialysis included Hong Kong at 68%, and that's because in order to do dialysis in Hong Kong, you have to do PD. The only way you can do hemodialysis is if you fail peritoneal dialysis. Followed by El Salvador, followed by Jalisco, Mexico, followed by Aguascalientes, Mexico, then Colombia, then Norway and Sweden, Canada 21%, Denmark 21%, and Iceland 20%. While peritoneal dialysis use has increased in some countries, such as China, Thailand, and the United States, it has decreased in parts of Europe and in Japan. Certain countries, including Australia, China, Hong Kong, Mexico, New Zealand, Thailand, and the United States, have implemented public policies to basically promote peritoneal dialysis use. And some of the countries have basically implemented peritoneal dialysis first policies. I mentioned Hong Kong as an example. Despite peritoneal dialysis being less expensive than hemodialysis, most patients around the world, upwards of 90%, are still receiving hemodialysis. Why is this? Well, a lot of times clinicians feel more comfortable managing hemodialysis than they do managing PD. A lot of patients prefer hemodialysis. A lot of patient comorbidities make peritoneal dialysis not possible. As I mentioned, a lot of clinicians just have a lot more experience working with hemodialysis. If you refer a patient late to nephrology and they don't have time for pre-dialysis education, sometimes they just get started on hemodialysis, among other reasons. Despite the lower costs associated with peritoneal dialysis, a global survey reported a 60-fold lower utilization rate of peritoneal dialysis in lower income countries compared with higher income countries. Although patients receiving chronic PD constitute about 11% of the global dialysis population, more than 50% live in only 4 countries: China, the United States, Mexico, and Thailand. Peritoneal dialysis is definitely less expensive than hemodialysis, but it's still expensive and it requires a lot of home resources. I mean, you have to have a home, you have to have a clean space in which to live, you have to have space to accommodate all the supplies, you have to be able to deliver the supplies to where they live. So there's still a lot of technical issues associated with peritoneal dialysis that make it difficult in less affluent countries. Consequently, hemodialysis is the dominant form of kidney replacement therapy, accounting for 80 to 90% of dialysis modalities. It's available in 98% of countries around the world, and mortality for hemodialysis patients is markedly higher than the general population. So compared with Age-matched general population controls and mortality hazard ratio for a hemodialysis patient is 12.6. So a hemodialysis patient is 12.6 times more likely to die than someone who is not on dialysis. In 2014, 80,000 kidney transplants were performed worldwide, although this covered only 10% of the total need. Rates of kidney transplantation were higher in high-income countries. According to the Global Observatory on Donation and Transplantation, kidney transplantation is non-existent in most of Africa and some countries of Southeast Asia. And specifically, Africa had a transplant rate of 0.4 per million population in 2015, simply because most countries just don't have a transplant program. In contrast, the United States, France, and Spain had the highest rates at 52 to 63 per million population worldwide. More recently, a study in 2023 reported a global median incidence of kidney transplantation of 12 per million population, ranging from 2 per million population in Africa to 42 in Western Europe. And the three countries that have the highest incidence of kidney transplantation are the United States, Spain, and Israel. Living donation kidney transplantation rates are the same among women and men. If patients choose not to undergo dialysis or transplantation, or if they simply don't have access to those resources, they are generally managed with what's called conservative care without kidney replacement therapy. So this is sort of a planned, holistic, patient-centered care for patients with advanced chronic kidney disease. Includes interventions to delay kidney disease progression, minimize adverse events and complications and symptoms, but it does not include the option of dialysis. And again, it might reflect the patient's choice. A lot of elderly people in this country just choose not to do dialysis, or it could be because of lack of choice. Say, if a patient doesn't have access to dialysis or transplantation. There's limited data on the prevalence and incidence of conservative care. There was a community cohort study in Canada that looked at 1.8 million adults and found that only 0.17% receive conservative care. Older women are more likely to receive conservative care and have reduced access to transplantation than men, and there are different reasons for this, including higher allosensitization associated with pregnancy. So if you've been pregnant, and as you develop antibodies that make it a little bit harder to match a kidney transplant. I want to spend a moment discussing African Americans in chronic kidney disease. In 2017, African Americans accounted for 30% of incident kidney failure cases, even though they only constitute 14% of the population of the United States. Compared with white Americans, black Americans have a 3.7-fold increased prevalence rate of kidney failure. And there are a lot of risk factors. Some may be lower income, socioeconomic status, greater rates of obesity, diabetes, but also genetics are likely a factor, specifically referring to something called the apolipoprotein L1 gene. The apolipoprotein L1 gene, or just APOL1 gene, encodes a protein that is a component of the circulating high-density lipoprotein, or HDL. Many of you have heard of HDL cholesterol. So this is part of the HDL cholesterol molecule. And it turns out that there are different variants of this particular gene. And these come from West Africa, and the variants are called G1 and G2. So if you inherit 2 copies of these, so either 2 copies of G1 or 2 copies of G2, or 1 copy of G1 and 1 copy of G2, you have a high-risk genotype associated with the development of chronic kidney disease and ultimately kidney failure. So a high-risk ApoL1 genotype is associated with a 10-fold higher risk of kidney failure due to a condition called focal glomerulosclerosis, and a 7-fold higher risk of kidney failure attributed to hypertension. Some, but not all, data suggest that if you inherit just 1 copy, so a monoallelic inheritance, 1 copy of this gene variant, that may also confer an increased risk of chronic kidney disease, though to a lesser degree than if you have 2 copies of the gene variant. The high-risk ApoL1 mutation is also associated with earlier onset kidney disease, so people develop kidney disease at a younger age. Kanji published a study in 2011 in the Journal of American Society of Nephrology looking at 407 African American patients receiving hemodialysis and found that those who had two of the gene variants, the mutant alleles, were significantly younger at the time of dialysis initiation than those who did not have any. Friedman published a study of almost 1,800 African Americans without known kidney disease, mean age 45. They were and found that the homozygotes, so people who had two copies of gene variants, were more likely to have protein or albumin in their urine and a reduced glomerular filtration rate compared to those who did not have the gene variants. And Parsa published a study. It was a post hoc analysis of something called the CRIC study, the Chronic Renal Insufficiency Cohort study, that looked at almost 3,000 patients, half of whom were black and half of whom were diabetic. And they were analyzed by race and according to the absence or presence of the high-risk APOL1 allele. And over a mean follow-up of 4.4 years, the glomerular filtration rate, or the function of the kidney, declined faster among black patients with the high-risk alleles than those who did not have it. Finally, I'd like to briefly highlight the morbidity and mortality associated with chronic kidney disease. Early stages of chronic kidney disease as well as end-stage renal disease are both associated with high morbidity and increased healthcare utilization. According to the USRDS data, so the United States Renal Data System, approximately half of all dialysis patients have 3 or more comorbid conditions. And as an example, in one retrospective study of 259 adult patients with chronic kidney disease, hypertension, diabetes, cardiovascular disease, and peripheral vascular disease were present at high frequency. Hospitalizations are also more frequent in the same study. 47% of patients were hospitalized. 47% of patients who had chronic kidney disease were hospitalized during a median follow-up of 11.4 months. And rates of hospitalization and of hospital days per patient year at risk were 3 times higher among those with early stages of CKD and about half when compared to those on dialysis patients. The self-reported quality of life is far lower in dialysis patients than in the general population. And in patients with chronic kidney disease, particularly those with end-stage renal disease, they're at increased risk of mortality, particularly from cardiovascular disease. So the survival probabilities on dialysis at 1, 2, and 5 years are 81%, 65%, and 34% respectively. And mortality rates for prevalent dialysis patients are in one study 7 times higher than those of the general population. Another study that I quoted you earlier, it was 12.5 times greater than the general population. Let's summarize what we've learned. The global prevalence of chronic kidney disease is high, ranging from approximately 9 to 13% in different studies, and is about 1.3 times more frequent in women than in men. Between 1990 and 2017, the CKD prevalence has increased by approximately 29%. Similarly, mortality during the same period has increased by 42% associated with chronic kidney disease, driven in part by population aging and population growth. And over that same period, chronic kidney disease moved from the 17th leading cause of death to the 12th. In addition to shortening life expectancy, CKD is also strongly associated with disability. There are regional differences in CKD burden, particularly in socioeconomically challenged countries, South America, the Pacific Islands. The burden of kidney failure is growing. Approximately 1% of the world's population is currently receiving some sort of kidney disease therapy, and this proportion will increase over time. Over 90% of patients with kidney failure in low and low middle income countries remain untreated just because they can't afford dialysis. Worldwide, hemodialysis is the most frequent treatment modality for kidney failure. So about 80 to 90% of people are on hemodialysis versus about 10 to 11% on peritoneal dialysis. There are racial differences in kidney failure. Compared to white Americans, black Americans have 3.7-fold higher prevalence of kidney failure. And in some cases, specific apolipoprotein 1 polymorphisms or gene variants confer a substantially higher risk of kidney failure in the black population. CKD has a significant impact on our healthcare community in terms of morbidity and increased cost. Okay, time for a quick quiz. Question number 1, what percentage of the world's population has kidney disease? That's right, so on average 10 to 15%. Question number 2, are men or women more likely to have chronic kidney disease, and are men or women more likely to need dialysis and or a kidney transplant? That's right. So women are about 1.3 times more likely to develop chronic kidney disease than men, and yet men are 1.5 times more likely to need dialysis or kidney transplant, in part suspected to be due to the fact that CKD tends to progress more rapidly in men than in women. Question number 3, what is the number 1 cause of kidney failure worldwide? You guessed it, diabetes. Question number 4, what is the prevalence of end-stage renal disease worldwide? That's right, 0.1% and growing. Final question, what percentage of dialysis patients around the world do peritoneal dialysis? That's right, about 10%. Okay, this concludes the March 2025 global tour of the epidemiology of chronic kidney disease. Thank you so much for your attention and for taking care of our patients. This is Andy Brokenborough signing out until next month.